A very good evening. So, welcome to the platform of Arise. So, myself, Dr. Ramyashree, I teach obstetrics and gynecology. So, today in this session of live clinical based questions and image based questions, we'll discuss as we are coming towards our exam. So, practicing the clinical based questions is very important. And OBG is one of the very scoring subject where you will get the maximum score. So we should be perfect with the subject of OBG, right? So let's start with the session and start with the MCQs. So let's start with the MCQs. Right. The first question is, clinical signs and findings of the presence of ovulation include all of the following except. Clinical signs and findings of the presence of ovulation include all of the following except A. Detection of urinary LH surge. Estrogen peak during secretory phase of menstrual cycle. Increase in the basal body temperature more than 0.5 degree Fahrenheit in the second half of the menstrual cycle. Presence of mitral smudge. Progesterone level more than 5 nanogram per ml 7 days before the expected menses. So all these are signs of ovulation except one. So you have to identify what is that one which is not a sign of ovulation. So I want you people to start answering, so that we can have a healthy discussion. Right. So I have an answer of B. Excellent. So detection of urinary LH surge is definitely a sign of ovulation. After urinary LH surge, usually ovulation will take place. From the onset of urinary LH surge to ovulation, it takes around 36 hours. Estrogen peak during secretory phase. Now, how many times does estrogen peak in a menstrual cycle? So usually the estrogen peaks around twice. The estrogen peak in menstrual cycle is twice. The first peak is around just before ovulation, just before LH surge onset. So around day 12 to day 13, you'll have the first peak. And the second peak in the second half of cycle. In the second half of the cycle, what is the predominant hormone? In second half of cycle, most of the time we all think that it's only progesterone which is present, but that's wrong. In second half of cycle, we have both estrogen, progesterone, relaxin, and inhibin A. On day 22, when you have maximum amount of progesterone, you also have the peak of estrogen. So very good, Gopal Krishna. So estrogen peaks twice, and that is one in the proliferative phase, one in the secretory phase of the menstrual cycle, right? But estrogen peak during secretory phase is of no significance for us to tell that she's ovulating. Estrogen peak in secretory phase can be there for conditions like PCOS and all. So it is not telling me that patient is ovulating. So it's not an indicator of ovulation. Estrogen peak in the second half is not an indication of ovulation. Increase in basal body temperature by more than 0.5 degree Fahrenheit in the second half of menstrual cycle is definitely an indicator of ovulation. Why? Because progesterone is thermogenic. So post ovulation, the temperature will rise by 0.5 degree Fahrenheit. What is mitral smudge? What is mitral smudge? So mitral smudge is the mid-cycle ovulatory pain. Mid-cycle ovulatory pain. So due to the ovulation, you're having the pain in the mid-cycle, that is called as mitral smudge. Last one is day 22 measurement of serum progesterone. This is a very good indicator of ovulation. Day 22 measurement of serum progesterone will tell us about the ovulation. How does it tell us about the ovulation? Day 22, if serum progesterone is more than 5 nanogram per ml, it's an indicator of ovulation. And day 22, if serum progesterone is more than 25 nanogram per ml, it is an indicator of pregnancy. And day 22 serum progesterone levels less than 3.5 nanogram per ml is an indicator of anovulatory cycles. So definitely day 22 serum progesterone is an indicator. So you should be knowing in this question actually indicators of ovulation. Indicators of ovulation was asked in the mid exam, so probably it can come for us, and there might be the questions. So recent this year itself, different types of exams. So from one exam to another exam, you can have a repeat. So in this year only, there was a question of which is a better indicator of ovulation. So the options were, right, I will tell you all the indicators of ovulation. Okay, don't worry. So the progesterone one you can watch here. The progesterone one, everything I'll tell you. All the indicators I'll quickly tell so that you will have a quick revision of it. So indicators of ovulation. You have indirect indicators, direct indicators, and conclusive. Conclusive is when patient gets pregnant. Obviously, when patient is pregnant, 100% she has ovulated. Direct indicator of ovulation is when there is laparoscopic visualization of Shreyansh, ask them not to shout. Close the door. Close the door and ask them not to shout. Direct indicators are laparoscopic visualization of corpus luteum. Okay. What are the indicators? Indirect indicators of ovulation. Now, Shankar, Deepu, you have told urine HCG radioimmunoassay. Urine HCG radioimmunoassay will tell me the pregnancy. So it will come under conclusive. Okay. Now, what are the indirect markers which tell us that she is ovulating? History-wise, indirect markers are when they have regular cycles. I want you people also to keep answering. Regular cycles. Just now I discussed one, mitral smudge, that is mid-cycle ovulatory pain. Mitral smudge. History में something else, PMS, premenstrual syndrome, and primary dysmenorrhea, primary spasmodic dysmenorrhea. That is pain present only for the first 6 hours of the menstruation. This primary spasmodic dysmenorrhea is because of the progesterone withdrawal leading prostaglandin release. These are history wise which tell me that she is ovulating. Okay. Now coming to the very good, excellent Mansi, cervical mucus changes. Under the influence of estrogen, cervical mucus will be thin, copious, and can be stretched between 2 fingers. Can be stretched between 2 fingers, which is called as spin barket. And how will be the smear? On smear, you will see the fern pattern. The fern pattern can be given as an image-based question. Okay. So on smear, you will see the fern pattern. Mid-aims may they ask, why do we have this fern pattern? Fern pattern is because of estrogen causing sodium chloride crystallization. What happens to the cervical mucus under the influence of progesterone? So post ovulation with progesterone, it will become thick, scanty, cannot be stretched, ferning absent. Ferning absent. So on stretching the cervical mucus breaks, which is called a tack for progesterone. Okay. Next is post ovulation, increase in temperature by 0.5 degrees Celsius, right? That's one indicator. So all these are history based. Investigation में urinary LH surge, serum progesterone on day 22, levels more than 5 nanogram per ml suggestive of ovulation, more than 25 nanogram per ml is suggestive of pregnancy. Next, endometrial biopsy on day 22. Endometrial biopsy on day 22. Endometrial biopsy on day 22 will show you secretory endometrium. What is the first sign of ovulation on endometrial biopsy, which is actually seen on day 14? First sign of ovulation on endometrial biopsy. Who can answer that? So I keep a dash because there is many times asked MCQ. They can describe it also. Next, on USG, you will see triple line appearance, rupture of dominant follicle, and minimal fluid in pouch of Douglas. Excellent, Mansi. The first sign of ovulation on endometrial biopsy, it is not on day 22, guys. On endometrial biopsy is very good. I see now many students answering very good, Prem and Gopal Krishna. So it is subnuclear basal vacuolation. Subnuclear basal vacuolation. Why do you have this basal vacuolation? It is because of the accumulation of glycogen below the nuclei. It is because of the accumulation of glycogen below the nucleus. That's called subnuclear basal vacuolation. Okay. One more last which I left here is the vaginal epithelial cells. So vaginal epithelial cells, we call it as maturation index. On maturation index, we take into consideration superficial cells, basal cells, and intermediate cells. Sorry, the order is different. It's parabasal or basal cells, superficial cells, and intermediate cells. Basal or parabasal cells are under the influence of no hormonals predominant, so it's usually 0. Superficial cells are under the influence of estrogen. Intermediate cells are under the influence of progesterone. Post ovulation, intermediate cells will increase, superficial cells will decrease. Okay. Post ovulation, cervical mucus will become thick. Before ovulation, cervical mucus will be thin. Under the influence of estrogen, it is thin. Under the influence of progesterone, it will be thick. So that's all about the indicators of ovulation. Indicators of ovulation. Let's see the next question. Okay. in the developmental progression from childhood through puberty to menopause, all of the following statements regarding levels of FSH and LH are true except. So one more point I'm discussing pertaining to the. Okay, Prem, I'll try to increase the size of the, what do you say, pen thickness, right? So FSH is suppressed from birth to 20 months of age. LH is increased during neonatal year. LH and FSH levels are reduced during childhood before puberty. At the onset of puberty, pulsatile GnRH drives the pituitary LH and FSH. LH and FSH levels rise sharply after menopause. Reproductive physiology is a very, very, very important topic and you should be always aware of it. So that's the reason why I've kept one more question on the reproductive physiology. Right. I see one answer as C. Okay, C. So you people consider that LH and FSH levels are reduced during childhood before puberty is false. Okay. How many of you agree with option E? LH and FSH levels rise sharply after menopause. How many of you agree with E? E is true or false? So normally we have the hypothalamo-pituitary ovarian axis. From the hypothalamus, so just a second, what I'll do is I'll put this on the OneNote so that you know the thickness of the. Very good. Very good, lovely Logesh, Prem Patel, and Shankar Deepu. You're all correct in telling that the FSH and LH levels increase in the menopause. Why the FSH and LH levels increase in the menopause? The FSH and LH levels increase in the menopause because of the rise in the, because of no negative feedback, because of the no negative feedback by FSH and LH, right? So now we'll not have the problem of thin. So this was the question which we had, right? So LH and FSH levels rise sharply after menopause. Many of you agreed it's correct, right? Why LH and FSH levels increase sharply after menopause? It is due to no negative feedback by FSH and LH. It's due to no negative feedback by FSH and LH. Sorry, no negative feedback by estrogen and progesterone, right? And how much is the level of FSH and LH post menopause? It will become more than 40 international units per liter. I strongly recommend that you should also know the level of FSH and LH, because many exams they have given the levels of FSH and LH and they try to ask an MCQ. Right. So E, I didn't have a doubt. Let me go to the D option. At the onset of puberty, pulsatile GnRH releases drives pituitary FSH and LH. How many of you agree? How many of you agree with option D? So this is also very appropriate. Why? At puberty, you have the pulsatile GnRH, and because of the pulsatile GnRH, you will have FSH and LH levels, FSH and LH being released. And FSH and LH are also released in pulses. FSH and LH also are released in pulses. So option D is also true. So I didn't have the doubt between option D and E. Let's go to the option C. A, B, C, we are little in dilemma because that clarity we don't have. But I think we should have one clarity that what happens to the FSH and LH from childhood to puberty is their low levels because there is no pulsatile GnRH. At puberty, you're having, so this too we had a clarity. After menopause, they are increasing. Can you see the beautiful graph? Menopause, they are increasing. See this one. The pulsatile, they're released in pulses, both LH and FSH. LH high amplitude pulses, FSH low amplitude pulses. This is because of the pulsatile GnRH. Everything is dancing in reproductive age group. GnRH also dancing, LH, FSH also dancing. Now coming to the childhood to puberty, no pulsatile GnRH, so FSH and LH will not be released. But from birth to 20 months, the withdrawal of estrogen and progesterone in utero will lead to sharp rise in FSH and LH. So from birth to 20 months, you have the sharp rise of FSH and LH due to withdrawal of endogenous estrogen and progesterone, which were there in the pregnancy, Okay. So this is a beautiful, image showing you about the LH and FSH levels throughout. Okay. Not only that, you should also know the tabular form of estrogen, progesterone, that one also. So probably one more class, I'll put that question. So if you come here now again, LH and FSH levels are reduced during childhood before puberty is true. LH is increased during neonatal period, birth to 20 months is true. Along with LH, FSH is also increased. Okay. As before I complete this question, I would ask you one question. What is one normally what will be more? FSH will be more or LH will be more? Or it depends on menstrual cycle, it depends on which half of the menstrual cycle which will be more. I think more appropriate to say that depends on the menstrual cycle. Second half you have more LH. First half you might have little more FSH, right? What is the condition where you have LH more than FSH? What is the condition where you will have LH more than FSH? So you think and answer, by then I'll go to the next question. So what is the condition where LH is more than FSH? 3:1. Excellent, Mansi. It is PCOS. PCOS may you have LH more than FSH. 3:1 ratio. 3:1 ratio. Right? Okay, then I have somebody answering pregnancy. Good. You know, as and when you answer, you tend to get more and more knowledge. I'm happy that you answered pregnancy. Please tell me what happens to the LH and FSH in pregnancy. What will happen to the LH and FSH in pregnancy? You can think and answer about that. Okay. Right. Let's go to this question by then. Which of the following occurs first in majority of the girls with normal pubertal development? Achieving peak height velocity, menarche, breast development, development of pubic hair, development of axillary hair. Very good, Shankar. Shankar is actually providing the answer. You know, actually the correct answer should be this followed by this. So very good. That's correct. Actually, you're correct. So ideally the correct answer should be growth spurt, but I don't have the growth spurt option. So obviously I'll go with breast development. So in the normal pubertal development, please remember the mnemonic of gross BPH in males. Gross BPH in males. First is growth spurt, followed by breast development, that is thelarch, followed by pubarch, followed by height, followed by menstruation. Okay. So growth spurt, breast development, pubarch, height, and menstruation. This is the order, gross BPH in males. That's the normal pubertal development. Okay. But the first sign is growth spurt. But first visible sign of puberty is breast development. Height is achieving peak height velocity. Right? So that's why the best answer here is C, breast development. Right. I have asked one more question here. What happens to the FSH-LH in pregnancy? FSH-LH in pregnancy is rich in estrogen and progesterone. Whenever you have high levels of estrogen and progesterone, what happens to the FSH and LH? High levels of estrogen causes negative feedback and decreases the FSH. High levels of progesterone causes negative feedback and decreases the LH. So LH and FSH levels are low in pregnancy. Okay. Next question. A 42-year-old woman presents to the labor ward at 34 weeks of gestation in preterm labor. 42-year-old. Is it fine, 42-year-old, or not so fine? What is abnormal about 42-year-old presenting to you in with preterm labor? She progresses very quickly and proceeds to have an emergency cesarean section for fetal distress. So she was progressing quickly, but baby couldn't tolerate and they had to go for emergency cesarean section. She was discharged home after 1 week as the baby was admitted to the special care baby unit because of preterm. 2 weeks later, she comes back to her general practitioner asking for contraception. She wants to continue to breastfeed her baby. So what is the contraception which you will advise her? A very beautiful question. So here you have to understand, if you want me to give you a clue, they're mainly asking 1 week she was in hospital, 2 weeks later she came. So 3 weeks post delivery, what is the contraception which you will advise? That's all is the question. 3 weeks post delivery, what is the contraception which you will advise? Okay, so the contraception of choice 3 weeks post delivery is progesterone only pills. Many times blindly the students go on asking what is the lactate, what is the pill, what is the contraception postpartum. You cannot tell it as a single line. What is the contraception of choice postpartum? It depends on case scenario to case scenario. Like this question, why IUCD is not the contraception of choice for this patient? Who can tell me why IUD is not a contraception of choice for this patient? Because write in bold in your notes. I want you to jot down these points bold in your notes if you are not aware. Okay. So postpartum contraception points. Condom is never a contraception of choice because failure rate is very high, right? IUCD can be inserted in third stage, that is as soon as the placenta separates or within 48 hours. Timing of insertion for IUCD is within 48 hours, or you can insert it after 6 weeks of delivery. Post delivery, post delivery 48 hours to 4 weeks. It's absolute contraindication to insert on IUCD. And this patient presented to you with 3 weeks. So it will come under absolute contraindication. Relative contraindication is between 4 to 6 weeks. So you should actually insert either within 48 hours or after 6 weeks. Okay. Right. Now coming to the POP. POP is the lactational pill, can be inserted, can be given any time postpartum. So usually we start 3 weeks postpartum. Okay. Coming to the OCPs. OCPs should be given after 6 months. After 6 months, if breastfeeding, very good, lovely Logesh, estrogen decreases the breast milk production. So OCPs should be given after 6 months if breastfeeding, and after 3 weeks if not breastfeeding. After 6 months if breastfeeding, if she's not breastfeeding, you can start them on OCPs for 3 weeks. Why? Because this is just going to disturb the breastfeeding. So if she's not breastfeeding, you can start after 3 weeks, right? Absolute contraindication to start OCPs post delivery to 6 weeks. If breastfeeding, post delivery to 3 weeks if not breastfeeding. Relative contraindication is between 6 weeks to 6 months. So I hope you all have a clarity now about the postpartum contraception. So it is never a single liner ki postpartum contraception IUCD is the choice or postpartum contraception POP is the choice. It depends on a case scenario. If patient present to you with within 48 hours, close your eyes and go for IUCD. I tell IUCD more on POP within 48 hours. But if patient presents to you beyond 48 hours, what should be your contraception of choice? POP. I hope you all have a clarity on this point now. So let's go back and go for the next question. Okay, why condoms are not advised? So the failure rate of condom, the typical failure rate of the condom is 18 per 100 women years, whereas perfect use failure rate is 2 per 100 women years. So you still have a high risk that patient can get pregnant. So when you're holding a risk that patient can get pregnant, how can you tell that this will be a contraception of choice, right? Copper IUCD, the failure rate is typical 0.8, perfect use 0.2. OCP, perfect use 0.1. POP, perfect use 0.3. Next question. A 36-year-old Asian woman attends the infertility clinic. See, whatever questions I'm discussing is nothing out of what you have learned. It's just I'm making you habituated to the clinical questions. Okay, how do you have to approach the question and how you have to answer it? Okay, so learn the approach and don't think I have to read some more or something. No, you have read enough. Now learn the approach. Okay. 36-year-old Asian woman attends the infertility clinic with her husband. She has been trying to conceive for last 2 years. She's overweight and gives a history of irregular periods over last 2 years. I think till here only if somebody tells me, I'm 100% sure that this is a case of PCOD, right? So her history and investigation is suggestive of PCOD. She's been using clomiphene citrate for last 6 months with day 1 progesterone suggestive of ovulation. I'll myself tell you here that this is suggestive of ovulation. Okay. Her husband's semen analysis normal. What is the management which you would like to do for her? You want the PDF of the questions? If you want, I'll send it. Okay. Definitely the purpose of now is to help you all so that you will get 200 to 250. So whatever possible help I can do, I always do that. So if you want the PDF, I'll definitely send it. Okay. Right. I want all of you to actively participate and keep answering. Very good. I have one person who has answered it correct. Excellent, Rajesh. You are correct in answering that. Perform laparoscopy and dye test. Can you tell why is your answer A? If you tell why is your answer A, it is like more, matlab super. Okay, let's rule out each question answer option. She is not being conceived since 2 years, and you have been giving her 6 months treatment. Now you will just tell counsel and offer support. Whatever support and whatever counseling you offer, she will not be satisfied. She wants bacha. Right. Now coming to the bilateral ovarian drilling. Why do you want to drill her ovary when it is producing oocytes? She is ovulating. On giving clomiphene citrate, she is ovulating. When she is already ovulating, why do you want to put a drill to it this? When will you drill the ovary? You will drill the ovary when she is not ovulating. But when she's already ovulating, there's no point in drilling her ovary, right? Excellent, Rajesh and Asmin Unisa. Very good. So there is no point of bilateral ovarian drilling, but please understand, she is ovulating and husband semen analysis is normal, but in spite of that, they are not getting pregnant. Don't you want to go out of the box and think probably this is not about ovulation, this is something more? Amen. So as this is something, before I go for any other thing, I would like to rule out other causes of she not getting pregnant. So I would like to rule out the tubal. I would like to check for the tubal patency. So as I would like to check the tubal patency, I'll do laparoscopy and dye test. Okay. So I repeat the concept here again. She is a PCOS, so they started her on ovulation induction. On giving ovulation induction, she started ovulating, but she couldn't get pregnant, although semen analysis is normal. Sir. Sir. So in spite of she ovulating and semen analysis normal, she is not able to get pregnant. So I would like to rule out the other causes of infertility, that is the tubal factors of infertility. So that's why I'm going for laparoscopy and dye test. Now, one more question I'll ask here before I go to the next question. Which is the most common cause of infertility? Which is the most common cause of infertility? The most common cause of infertility is anovulation. Anovulation. Right. Let's go to the next question now. Very good. PCOS also you can tell it as mainly anovulation. An infant is born with ambiguous genitalia. Although amniocentesis analysis during pregnancy showed a 46XX genotype, the infant has phallic appearing genitalia, partially fused labia. You cannot palpate testis. Aside from a standard blood test, which biochemical screen is indicated? What are you suspecting? 46XX with ambiguous genitalia. What is the most common cause of ambiguous genitalia in female? Excellent, Shruti. You're correct. So the most common cause of ambiguous genitalia in a female karyotype is, very good. I see many of you answering this question correct. Very good. Excellent. So the most common cause of ambiguous genitalia in a 46XX is, you're all answering correct, but can you tell me what is that? Is congenital adrenal hyperplasia. Very good. Is congenital adrenal hyperplasia, mainly 21 alpha hydroxylase deficiency. Mainly 21 alpha hydroxylase deficiency. So, how can I confirm the 21 alpha hydroxylase deficiency? I can confirm the 21 alpha hydroxylase deficiency by measuring the serum 17 alpha hydroxylase progesterone. Now, let's quickly go through the congenital adrenal hyperplasia. So in the adrenal gland, for the production of aldosterone, cortisol, and estradiol, you have these happening. That is, from the pregnenolone, you will have the aldosterone forming. From pregnenolone, you will have the cortisol forming. From pregnenolone converting into DHEA, you have the estradiol and testosterone forming, right? This formation requires 3 beta HSD as well as 21 alpha hydroxylase dehydrogenase and 11 beta hydroxylase dehydrogenase, right? But whenever they have the absence of 21 alpha hydroxylase dehydrogenase, what happens? The pregnenolone will become progesterone, but it can no more further become aldosterone. So they have decreased aldosterone, and this also cannot get converted into cortisol. So they have decreased cortisol. So all this progesterone and pregnenolone and progesterone will start becoming DHEAs and androstenedione. And that androstenedione decreases the production of testosterone. This testosterone, increased testosterone, who decides what will be the external genitalia? To start with, external genitalia is neutral. Matlab, it is neither female nor male. Who decides what will happen to the external genitalia? External genitalia will become female if there is exposure of, if there is no intrauterine testosterone. External genitalia will become male if there is intrauterine testosterone. Here, there is intrauterine testosterone, that to increased levels. That's why external genitalia is becoming like male, partially like a male. It's neither like a female nor like a male. That's why we call it as ambiguous genitalia. So I repeat again, congenital adrenal hyperplasia mein you have 21 alpha hydroxylase deficiency. So all the progesterone and pregnenolone are getting converted into testosterone. Testosterone is the one which decides whether it will become the male external genitalia or female external genitalia. If you have in utero exposure to dihydrotestosterone, it will become male. If you don't have the in utero exposure to dihydrotestosterone, it will become female. It has nothing to do with your karyotype or uterus or anything. It's just like a mathematical formula. So they will have ambiguous genitalia. Apart from ambiguous genitalia, the classical CH can also have, as there is decreased aldosterone, they'll have salt wasting. So sodium cannot be conserved. So they'll have decreased sodium. So salt wasting. And they'll also have symptoms of decreased cortisol. And how can you diagnose this? So there will be more levels of 17 alpha hydroxy progesterone because they are getting converted into androstenedione. All pregnenolone and progesterone is becoming 17 hydroxy progesterone. So you'll have more levels of 17 hydroxy progesterone. Can you diagnose this and treat it antenatally? Inside. Yeah, antenatal itself. Can you diagnose and treat antenatally? Yes, you can diagnose and treat antenatally, as well as you can treat postnatally. Antenatally, give cortisol. Give steroid. So we give dexamethasone. Once we give dexamethasone, the testosterone levels will decrease. And it will help them not having the ambiguous genitalia. Okay. Right. So let's go to the next question. A 28-year-old nulliparous woman is referred to the colposcopy clinic by her general practitioner. She's up to date with smears and never had any previous abnormal smears other than current cervical smear showing mild dyskaryosis. Just give me a minute. Shansh, can you go out? So just read this question and try to answer. No, Prem, antenatally, see, probably if she had a previous congenital adrenal hyperplasia baby, I suspect again she can have the disease. So as again she can have the disease, when I'm suspecting again she can have the disease, I'll try to do the karyotyping and check for the deficiency or the mutation. Okay. When it is clinically indicated, it's not a contraindication. Right. So with this question, a 28-year-old nulliparous. So colposcopy shows she is having mild dyskaryosis. Mild dyskaryosis is equivalent to CIN1 or LCIL on pap smear. So that's why they did colposcopy. Colposcopy mein mild acetovite area at 11 o'clock. And it is satisfactory. Satisfactory means transformation zone is visible. So what should be your next step? So I have Mansi answering. What about others? A very simple question. So first and foremost, whenever you have an abnormal pap smear, will you treat based on abnormal pap smear or will you go for confirmation of that pap smear? Whenever you have an abnormal pap smear, you'll always go for confirmation of that pap smear, right? So what will you do to confirm that pap smear? So to confirm that pap smear, we will always go for colposcopy. So here also they went for colposcopy. So that point is okay. On colposcopy, they saw an abnormal area at 11 o'clock. So what should be your management? There is an abnormal area at 11 o'clock. Take a biopsy of it. So punch biopsy of that cervical lesion. Simple. So what did you understand? Most of the questions are just logical thinking and understanding them. That's only is what required. Okay. So as you have an abnormal lesion, you are taking the biopsy of it. So that's why you're doing the punch biopsy. So I didn't ask any specific management here. I'm just asking what you do one after the other step. That's all. One more question on cervical cancer. Stage 1B cervical cancer is diagnosed in a young woman. Assuming the cancer is confirmed to the cervix, confined to the cervix, and that intraoperative biopsies are negative, which of the following structures would not be removed during radical hysterectomy? Uterosacral and utrovesical ligament, pelvic lymph nodes, entire parametrium on both sides of cervix, both ovaries. Very simple question actually. Don't be scared of radical hysterectomy and all terminologies. So the clue I give you is cervical cancer never goes to that organ, and during surgery we always preserve that organ. So what is that organ which we are going to preserve when you're doing cervical cancer surgical management is my question. Excellent, very good, Shankar and Chakri. So cervical cancer, 99% never goes to ovaries. So in initial stages of cervical cancer, when you're doing surgical management of cervical cancer, whether it will be radical hysterectomy or whether it is modified radical hysterectomy, I'll never remove ovaries. Ovaries are preserved. So that is the important point. So ovaries are preserved. During surgical management of radical hysterectomy. Ovaries are preserved during surgical management of radical hysterectomy. Indeed, ovaries are preserved during surgical management of cervical cancer. So what we do is we take the ovaries from the pelvis and we put it in a paracolic gutter. Mano aage jaake if we have to give radiotherapy also, still we can preserve the ovaries karke. Okay. And which stage to which stage you will do surgical management in cervical cancer? So I have a very simple way of remembering it. I hope I have taught you, or I don't know I taught you, but I'll repeat it again. The simple way of remembering how do we do the surgical, which stage, what management. Staging starts from which stage? Stage 1A1. Keep A1 constant. After A1, after 1, what is the next number which you get? After 1, the next number is always 2. So from stage 1A1 to 2A1, you will do surgical management except 1B3. So from stage 2A2 to 4B and 1B3, you will do concurrent chemoradiotherapy. Simple. So management of CS cervix, if you remember this much, I assure you all the questions you can answer. And ovaries are preserved in surgical management. So keep A1 constant, 1 to 2, except 1B3. 1B3, 2A2 and 4B, all that concurrent chemoradiotherapy. Types of hysterectomy, I'll just go through it once. You can just have a look once. Okay. See, this is the point. Don't overload your brain with any new information. It should be like a revision and approach to the questions. So don't bombard your brain or pressurize your brain with anything. So keep it simple and more confident. That's the most important. One quick, in case if it comes, you will have an idea. That's all. So type 1 is the simple extrafacial hysterectomy, where you remove only the uterus. Vagina is not removed and uterine artery is ligated near the uterus. Type 2, upper 1/3 of vagina you will remove. Uterine artery where it crosses over the ureter, and ligaments also are removed midway. So uterine artery you will ligate where it crosses over the ureter. Type 3, upper half of the vagina you will remove. Uterine artery from its origin, whole length of the ligaments is removed. Type 4, upper 3/4 of the vagina, superior vesical artery is also removed and ureter is removed. Type 5 may even bladder and ureter also removed. Type 2 is called as Wortham's hysterectomy. If you can't remember all these, at least remember Wortham's hysterectomy carries highest risk of ureteric injury because you are ligating ureter in the Wortham's canal. So it carries a highest risk of ureteric injury. Type 3 is called as Meig's radical hysterectomy. Type 4 and type 5 are radical hysterectomies. So that was today's session. So I hope you all enjoyed through the MCQs. Tomorrow I'll be again coming back. I'll be taking 5 sessions like last month, 5 clinical based sessions. So today I discussed more of gynec. So tomorrow probably I'll go with OBS. So that way I'll try to jump and try to solve more and more clinical based MCQs, both gynec and OBS, as well as image based images. So that whatever we discuss, 90% of them should come in the exam, luckily. No? Right. Before I close the session, any queries you have pertaining to OBG and you want to ask them? Any queries? Or I think we can do one last MCQ and close the session, right? Yeah, image. What is the instrument which you're seeing in this image? Yeah, one last question before we end. What is the instrument which you're seeing in this image? So it has an angulation and jaw-like. Jaw-like. Excellent, Mansi. So this is nothing but a cervical biopsy forceps or punch biopsy forceps. This is a punch biopsy forceps. So nowadays they're also asking instruments. So every clinical scenario where you're discussing, we'll try to include some instruments so that you finish the instruments. So whenever you have a visible lesion on the cervix, you use this punch biopsy. How do you identify? Is it is angulated. This angulation you have to will help you in identifying. Okay, I'll send the PDF to your coordinator so that he can share it with you all. Okay, don't worry. Right. So thank you guys. All the best. Keep studying. Last few days are very important. So just go on studying and be confident. So I'll again come back tomorrow with some more MCQs. Thank you.